So we have about 15 minutes for Q&A. And thank you again to all the presenters for providing this wide range of examples and experiences from across the globe. Really interesting to see how all these issues take life in different contexts. And then, of course, as I said earlier, how do we engage with different groups to address similar issues? So I'll go straight into the first question, which I will pose to Mohammed. And I invite the audience, please, to continue sharing your questions. We'll try to take as many as we can. So Mohammed, one of the questions raised is about the lack of sustainable availability of vaccination cards for parents and clients, especially in countries that perhaps may have weak health systems or have challenges that prevent them from having this sustainable availability. Surveys show large discrepancies between card availability and validation and recall. And this is, to a large extent, due to the fact that parents don't have on hand their own record of their infant's vaccination in the first year or 4 years later. So how do we collectively work to ensure availability and use of vaccination cards to address some of these challenges? How do we also take into account this particular issue when it comes to migrant communities, which is an issue that a lot of countries now in Latin America are also facing, for instance, given some of the migrant communities moving from Venezuela to other countries. So if you could just address that particular challenge, please.
Thanks. It's a really good question, and I'm not sure if I have really a perfect answer. It's a complicated one. It's one that we've been looking at. I think all of us are thinking of what kind of solutions can be used. And in Bangladesh, we saw something very similar where the Rohingya population, we really could not ascertain their level of immunization. And we had to do a sera survey, in fact, to be able to get an idea of the baseline coverage that they were having coming into Bangladesh. But obviously, you can't keep doing sera surveys. That's not a sustainable way of understanding the issue. So I think we really got to look at technology. We're seeing a lot of new innovation coming out in terms of having copies of the card inserted into people's phones. But we know, the same issues we've seen with cards being lost or damaged. Phones can also, you can also lose your phones and damage it. So it's a really tricky, difficult issue. Something else I've seen have been tested out in Nigeria are these bracelets that they have dual purpose. One, to retain the record. They're very simple, low tech. And then they can also serve as a reminder. So they light up, and then different lights have different meaning in terms of which vaccine the child is receiving and which one the child is due for. So they've done some evaluations with it. They haven't published the results yet, but I think some of those kinds of innovations are really going to be important. But also the home-based, paper-based card records, I think we have to find ways to make them more durable, because some of the issues we've seen in a lot of contexts is that the cards get damaged, and then after a while, people just lose them because they get damaged. So I think we got to find some low-tech solutions, as well as finding some quote-unquote more high-tech but simple solutions that may be appropriate for different contexts.
Thank you, Mohammed. Very interesting response. It certainly requires that sort of a nuanced approach, as you highlighted. I'm going to ask the next question, and perhaps ask Leslie and Luis and Patsy to share their views on this particular question. How do we engage religious and faith leaders in a sustainable way to ensure that they remain as allies to address resistance and boost confidence? What are your views in terms of working with religious leaders and ensure their engagement throughout these processes? Would you like to go first, Luis?
Yeah, I'm happy to go first. Can you hear me?
Yes.
Yes. We had a very positive experience, as I mentioned, during the TIP project, and the rabbi that had the lead for health was very engaged with the whole project from beginning to end. He was all very clear to mention, however, that if you have one religious leader who's engaged. It doesn't necessarily mean that, you know, from the synagogue down the road, you will get the same level of engagement. So it does become a continuous process. And I do agree that there is some degree of difficulty with sustainability of these things because they are very time consuming. Some of the other challenges that were mentioned were along the sort of the degree of, I can't remember what someone called it, one-offism or something, that it's one thing, and the rabbis, religious leaders have lots of different issues. The Haredi community in particular had a lot of different challenges, of which immunization was just one. So it can be very challenging, but we find it by inviting them from the beginning, by making sure that community leaders were involved at all stages, that they were very engaged, they were very welcoming. And we also found that cultural awareness training was very helpful. So some of the community members provided that to healthcare professionals so that they were aware of the community's beliefs, and when they had religious holidays and when they had their religious services, etc. So they knew not to invite them to appointments on those kind of days. So being aware of the religion was very important as well. But yeah.
Thank you, Luz. Patsy, go ahead, please.
I would just add that I think for us, learning that, you know, imams were not a homogenous group. It was a diverse group of opinions and thoughts. And as we looked at when the outbreak began, half of the parents were vaccinating their children and the other half weren't. And as we talked to them, those who were vaccinating said, well, my imam really promotes this, and this is really important in our family. Or I saw measles in Somalia before I came to the United States. So they're personal experiences, but they often did mention their religious leaders. When Andrew Wakefield came and invited in the imams, there was probably mixed opinions from them as they went in to hear him. As they left, of course, his charismatic message changed their minds to make sure that they brought his message, which was to not vaccinate. And what some of them told us was, this was the first time a doctor talked to us. And it wasn't really, but I think they felt heard, and they felt special, because he was sort of, you know, billed as a famous person. He wasn't a physician any longer, and he wasn't telling the truth, but they felt heard. And we have to learn from that. We have to say, okay, well, we need to be the ones that are there to share that. And so the imams then, as we had those going out to the mosque, they did ask us some very direct questions, like, where have you been? Where were you when we were worried about this a few years ago? And we were doing one family at a time, that one-on-one trusting relationship. And the message is, you have to do all of it. You have to make sure that the community is engaged, that it's a patient provider engagement, that it's a larger system communication as well. And interestingly, when we found out about how similar what was happening in Sweden and England with MMR causes autism myth just really dropping rates of vaccination Somali children, we said, what is going on? Well, it turns out there is an imam weekly phone call that's international, that people can get on the phone and just talk about whatever topic. This topic came up. And so you can see how that could very quickly spread across the world. Wherever Somalis live, they were listening to false information about MMR causing autism. So we have to use same kinds of methods and crawl our way back.
Thank you. One question to share with Kat and Carissa regarding whether the presence of COVID-19 is shaping conversations about other kinds of vaccinations. For instance, in the US, you know, the flu, or in the areas where you work at on any other specific issues. Do you have any thoughts on how COVID-19 is shaping those conversations?
I mean, I suppose I'm aware of the impact that COVID-19 has had on the chartered vaccination programs. So in Kyrgyzstan, for example, they froze the program for 3 months. So no children, no children were vaccinated, could even possibly be vaccinated in that 3-month period. And then in Bosnia and Herzegovina, where they really struggle with very low coverage, it was doing a little bit better after the TIP project, and it's plummeted again through COVID-19. So I don't know the data or the detail behind that, but that's what we've been hearing from our partners in those countries.
Thank you, Clarissa.
And in Washington State and through Vax Northwest, we've been talking about COVID. We definitely saw, like other places, the drop in childhood vaccines, but those are recovering. But I do worry, we have a large Somali community. I do worry about them recovering at the same rate. And the other thing is targeting. We're very interested, and I specifically, and a colleague of mine, another anthropologist, are very interested in making sure we understand how different communities are going to respond to COVID and the COVID vaccine. So if anybody knows of funding out there, we are very interested in doing some work to really understand community reactions. There is a challenge, I think Sean mentioned, that we don't really know what the vaccine looks like yet, what the side effects might be, how long the coverage will be. So that's kind of challenging to have those conversations with specific communities if you don't really know what the shape of the vaccine looks like. But I think that's definitely something we're thinking about, and we would love to think about how you would adapt some program like Community to respond to the concerns of specific communities, to COVID specifically, or just childhood vaccines as well. I know they're totally different things, but I think we're hopeful that we could do some adaptation.
Thank you. Patsy, very briefly, if you could share any recommendations for unique communication strategies for immigrant communities in the US on contact tracing or considering a COVID vaccine, for example, in a closed community of Marshall Island immigrants.
Yeah, I can't speak specifically to the Marshall Islands, but I think the principle is you want people who speak the same native language, who they are from the same community, and if they can partner with, or even better, be employed by public health or partner with public health, I think that really increased the trust.
Thank you. And very briefly as well, Mohammed and Luis, since you are in two different continents, or at least Mohammed, your work focuses in Africa primarily, and then Luis in England. Any final reflections in terms of how the work you've done and the lessons learned you've shared can actually inform efforts to, or are informing efforts to introduce eventually the COVID-19 vaccine?
Yeah, I mean, I think it goes back to this issue of not waiting until you have a problem, because we need to anticipate what the issues are and start the engagement now, and leveraging the existing structures that are there. And I think a lot of speakers have talked about this point, not just going when you have a problem. It's avoiding the spare tire problem. I think if we start some of the planning now, we start some of the engagement now, I think it's important. Just because we don't have a specific vaccine that we can rally around right now doesn't mean we cannot start the engagement. And it all goes back to the point where I think the social mobilization structures, the more we can have them be ingrained and sustained within the community and can be used for cross-cutting issues. So it's not just a matter of coming in when we feel like we have our public health objectives, which is kind of like top down, but have this more organic bottom-up engagement that continues beyond one epidemic or one health emergency. I think that is important. And Rafael, as you know, that was an important lesson we learned also from West Africa, was that, we need to build on existing structures and keep the dialogue going, keep the engagement going, and bring communities into the conversation and understand that they want the same things that we want. But as I think in the opening remarks on day one, they have different values that they bring. So we have to understand those values and see how we can align our communication, our efforts with those values that they have.
Thank you. Luis, very briefly.
Yes, in England, we're already preparing for potential COVID vaccination, and we are preparing a very comprehensive communication strategy, and we're doing some work now with high-risk groups, which include some of the groups that we've mentioned today, doing some qualitative work and some surveys as well around what they feel about potential vaccine and also coming to be vaccinated in the situation as we currently find, where general practice, etc., are places where people don't want to go just at the minute in case they get infected.
Thank you. Really appreciate everyone's time and presentations. Very interesting work. I would, in closing my role here, I would say that the point about really focusing on engagement of communities and parents and any relevant group is something that needs to happen continuously. It shouldn't happen at the moment when we have the problem. It really has to be part of the system. So I think that's a critical message that I think we're hearing from your presentations and from other presentations as well. So with that, thank you again, and I will turn it over to Walter for his final thoughts and remarks. Over to you, Walter.